Let's do it. Okay.
Right.
Hi. So my name is Helen Hocknell. I'm a volunteer with NAMI. I teach family to family and train teachers for NAMI basics. I also serve on the board for NAMI Montgomery County as secretary. It's just a great organization. I'm really happy to be involved. I've been volunteering with NAMI for several years now. And I'm delighted to be a moderator today. So just a few things to cover. This workshop, in case you're in the right room or not, is mental health crisis management and de-escalation techniques, presented by Oleg Tarkovsky from Care First Blue Cross Blue Shield. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website, which presumably you found because you're here. In this workshop, NAMI defines a mental health crisis as any situation in which a person's behavior puts them at risk of hurting themselves or others, and or prevents them from being able to care for themselves or function effectively in the community. In this presentation, we will discuss the different ways to identify mental health crises, various approaches to management of the crisis itself, including verbal and nonverbal de-escalation techniques. If this is not the workshop you meant to attend, please click the back button on your browser or click on the sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We'll be addressing questions at the end of the presentation. We'll definitely leave a few minutes for that. If you have any questions during the presentation, please use the Q&A rather than the chat. I'll look at both, but that's where you're supposed to put them at least. On the right-hand side of your screen, we'll review questions as they come in, and if something particular is unclear or needs to be expanded, we'll ask the presenters to go into that after their presentation is concluded. We are pleased to offer closed captioning for this year's conference, which I'm sure everyone will be repeating throughout the day, but in case you missed it, at the bottom of your screen, you'll see the little CC icon. That's only if you're on a desktop. If you're on a mobile, it's not going to work for you. But it's actually quite effective, and I was surprised at how clearly it gets all the words. If you have any comments, questions, concerns, or technical issues, please post them to our chat, and our technical assistant, I'm sorry, what's your name?
Nee
is here to help us with tech stuff. And we'll get to those if you put them in the chat. So I'd like to welcome our presenter for today's workshop, Oleg Tarkovsky.
Thank you, Helen. Good morning, everyone. Great to see a nice group here. We got about 30 people here on the call. I know I stand between you and lunch, so I will definitely try to finish on time. Just a quick introduction about myself. I am currently in a role of Director of Behavioral Health at Care First Blue Cross Blue Shield. I've been with Care First for about 3 years now in this role. Prior to Care First, I was with the Shepherd Pratt Health System. I was the divisional director of their outpatient services. I currently still hold my license in the state of Maryland as a psychotherapist, licensed professional counselor. I'm also an adjunct professor of psychology at Towson University, and I've been doing that job for about 15 years. I love teaching, and so presenting to you today is really one of my passions. Feel free, as Helen said, put your questions in the Q&A, and I would love to address those at the end. I will definitely leave us some time for a good discussion and conversation. So why don't we go ahead and get started. See, hold on one second here. Let's see. What's going on here? I can't move my slide. Let's try this. Okay, can you guys see my slides moving now? Just a thumbs up would work. All right, perfect, thank you. So before we get into the content, we will be talking about things that are potentially disturbing, especially if you have personal experience, if you have history of trauma. We'll be talking about suicide. We'll be talking about physical violence. And so if at any point you feel like you need to step away from the presentation, please do so. And I actually encourage folks to sort of as you pay attention to the presentation and topics come up that may be triggering for you, go ahead and step away. So what are we going to learn today? You will definitely learn sort of the basic definitions when it comes to mental health crisis. You will learn what one can do to assess the risk associated with mental health crises. You will learn some skills and hopefully learn how to apply those skills in different environments when it comes to mental health crisis and managing those crises. I think most importantly, I will teach you some verbal and nonverbal skills that could be used in a de-escalation situation when it comes to behavioral health emergencies, mental health crises. And if at any point you feel like you can't handle a particular situation when it comes to a crisis, I will show you and give you some resources to be able to connect those folks needing support with professional help. We have lots of professional help available, especially in this region of the country, and I will share with you how to gain those resources. Lastly, before we dive into the content, this is not meant to replace professional help. Yes, you will learn some of the skills, techniques. You will get lots of information as it relates to behavioral health, mental health crises. But we still have lots of professionals in this region and around the country available to help folks if they are in a crisis situation. If you yourself are in a crisis or somebody close to you is in a crisis, please know that 988 is available 24/7, call or text. Please use this number. I think throughout this conference, you will hear this number over and over again. In years past, we would have probably had 911 here on the screen, but now that 988 is available, it's a much more preferable way to address mental health, behavioral health crisis and emergency rather than calling 911. All right, so let's get started. First of all, I want to sort of flush out some of the definitions. The topic of this presentation is mental health crisis. Often these types of crises are in situations where someone with a mental illness is at the center of the crisis. In this country and around the world, folks have been using these two terms, mental health and mental illness, somewhat interchangeably. And I would like to share with you my opinion on these two names and titles and how they're related to one another. So despite of this sort of common belief that they are same things, we have now known from scientific research, especially from the writings of a sociologist named Corey Keyes from Emory University, that they're actually not the same things. So if you think about mental illness and mental health for that matter, most people believe that they are on a continuum. And that's probably a reasonable assumption to make, where on one end, you can have a very severe illness, like let's say schizophrenia, for example. And on the other end, you have no illness at all. And so the assumption most people make is that if you don't have an illness, well, you must be well. That is unfortunately not true. We have known this fact, not necessarily in the behavioral health world, but in overall health and physical health space for roughly 70 years. What you're reading here, the quote at the top, this is from a preamble to the World Health Organization's constitution from the late 1940s. And the idea here is that the mere absence of disease or infirmity does not mean that you're well or healthy. And so roughly 20 years ago, Corey Keyes published his first paper looking specifically at behavioral health. And he defined these new terms where instead of thinking about this on a single continuum where illness is on one end and wellness on the other, he introduced the concept of this matrix where we have multiple continua, where mental illness, for example, could be graphed on a horizontal axis, and mental health on the vertical one. Mental illness can still follow this pattern with the most severe illness on one side and no illness at all on the other. And mental health, if you look at the continuum of mental health itself, separate from mental illness, he coined these terms languishing, which describes a low degree of mental health, and the term flourishing, which describes a high degree of mental health. Most people, in this country at least, are somewhere in the middle. This is the moderate mental health range. And there could definitely be an overlap between folks with a mental illness and flourishing, people without a mental illness and languishing. So for example, situational influences, environmental influences, the pandemic, for example, has caused most people around the globe to experience some degree of languishing, where their overall mental health has struggled or suffered. But does that mean that they can be diagnosed with a mental illness? Not necessarily. As you have heard these statistics before, and they haven't really changed much in the last 20, 30 years, according to CDC, roughly 1 in 5 or 20% of general adult US population will be diagnosed with a mental illness in any given year. This is what we call prevalence of mental illness. Well, that still leaves another 80% without a diagnosable mental illness. Does that mean that they're always mentally healthy? Not at all. And so in many cases, just because you have a mental illness does not guarantee that you will end up in a mental health or mental illness emergency or crisis. And just because you don't have a diagnosable mental illness does not mean that you can never be in a mental health crisis or an emergency. So I wanted to set this up for us. So from now on, as we use these terms, and I'll still use the terms interchangeably in my presentation, just because most people are familiar with these terms. But the more people get to understand what they mean, I think the better we'll be able to apply them to real life situations. Okay, let's define crisis a little bit further. So as Helen introduced the presentation topic a few minutes ago, NAMI has its definition of mental health crisis. And you can see it here. And the basic components of that definition have to do with A, that it could be in any situation where a person's behavior puts them at risk of hurting themselves or someone else. It also means that it prevents them from being able to care for themselves or function effectively in a community. We'll talk a little bit more about what we mean by function and even the term community. Some of the situations that this includes is intense emotional distress. I think every one of us on this call today have been in a situation where our emotions have been flying high, sometimes in a good way. We often talk about emotions in terms of them being positive or negative. This is one of my favorite topics to lecture on. We're not going to dive deep into this, but just know that from a neuroscience perspective, there's not really such a thing as positive or negative emotions. Instead, most emotions, if not all, are either constructive or destructive. They can either help us navigate through the world and flourish, as Corey Keyes would say, or they can destroy our ability to function or navigate the world, ending us up in that languishing realm. Anytime an individual struggles with their daily functioning can also lead to a mental health crisis. But I don't mean just a little bit, so sort of feeling a little blue or under the weather. I'm talking about glaring changes. So all of a sudden, you're unable to take care of yourself or your loved ones. You can't get up in the morning. Or the opposite, you can't sleep through the night. Or you're not able to execute your parental duties if you have children. Or you're not able to do your work or focus on being productive at your place of employment. A couple other examples. include a loss of touch with reality. Typically, this happens in situations where folks are struggling with psychosis. So diagnosis such as schizophrenia. A few symptoms of someone with schizophrenia include hearing voices or seeing things that are not there. Well, obviously, that is not reality, and therefore the individual loses touch with that reality. We'll talk about this in a few minutes when we describe specific situations when this happens. The most obvious one is danger to self or others, and that is what we're going to spend a lot of time talking about today. What do you do if either you yourself or someone close to you finds themselves in a situation where they're a danger to themselves or others? And then there's also risk of harm due to substance use. Again, throughout the morning, you've heard other presenters talk about the increased use of substances in the last couple of years. And sadly, that increased use of substances has also led to inappropriate use of those substances, and in many cases, leading to overdoses and deaths. So much so that last year, we've seen the highest number of people die as a result of an overdose. Let's start walking our way through some of the risks. And again, as I mentioned a minute ago, the highest risk we have is that of homicide and suicide. What is a homicide? Well, homicide is when one's life is taken by another. So someone being murdered is a homicide. A suicide is when an individual takes their own life. A quick question. I know I don't expect you, we don't have a poll here, but just think to yourself for a second. In the United States today, do you think more people die by homicide or by suicide? Give you 3 seconds. It's suicide, and it's not even close. And so every time from now on, hopefully when you hear debates about gun control, gun violence, just know that even though in those conversations we often talk about homicide, many more people die by suicide using those guns and weapons than they do by homicide. There's also non-suicidal threats of self-harm. Cutting, hurting yourself with other tools, potentially weapons, potentially medications that are not meant to be lethal. There's all sorts of ways in which individuals can attempt to harm themselves without truly intending to end their own lives. Extreme lack of caring for oneself means in situations where the individual does not have the faculties to be able to take care of their ADLs, activities of daily living. So things like feeding themselves, dressing themselves, making sure that their immediate living quarters or environment are safe in terms of temperature, in terms of being clean, free of rodents. All those kinds of situations can present a huge risk to the individual and potentially individuals that that person is associated with. Dangerous behaviors with potential to harm others. So this is probably the area of risk that many people on this call are interested in finding out more. And in the next few slides, we'll go over the different ways in which we can handle those situations, even without professional help. On the previous slide, I mentioned psychosis. So this is where we talk about hallucinations. Typically, visual hallucinations are less threatening than auditory hallucinations, because often in cases of auditory hallucinations, this is where an individual hears voices in their head that are not really there in their actual present environment. They could have what we call commands of harm, where a voice tells you to hurt someone else or to hurt yourself. And those are some of the more dangerous situations. And then lastly, the risk of overdose from substance use. This is, as I mentioned a minute ago, ever increasing risk due to the predominantly the addition of fentanyl to the already dangerous drug use behaviors. So, for example, nowadays, you never really know what you're getting, especially with street drugs, because there's always a chance that those drugs, anywhere from marijuana to heroin, could be spiked with fentanyl. And it takes just a little bit of fentanyl to overdose and potentially leading to death. And so this risk of overdose from substance use has increased exponentially. We're talking 10 times greater if fentanyl is present in those substances. And so maybe an individual is participating recreationally in using a drug without really understanding the risks associated with the presence of fentanyl in that drug. So what could possibly cause these crises? Well, the short answer is we don't really know. It could be a million different reasons. But here are the top ones that we do know for certain. History of trauma and violence probably takes the cake here. And that is typically because traumatic experiences, especially violent in nature, leave a significant emotional imprint in our memories. And that imprint does not go away. And sometimes it's there for the rest of our lives. How those emotional memories are triggered later on in life are very unpredictable and typically can lead to a mental health crisis situation. The second, probably most frequent cause, which we don't often talk about, is the genetic predisposition. And again, there's very little you can do about genetic predisposition. We're all born to a set of parents who pass on their genetic code to us at birth. And then those are the cards we're dealt to live with. So the actual ability to change, at least today, living in our times, is very low. And so these are just some things we should pay attention to, but not really something we can do much about. A major loss or a significant change in someone's life is probably the most dominant condition today that leads to a mental health crisis or behavioral health emergency. Because folks lose others in their lives very frequently. It could be our family members, friends, coworkers. Significant changes happen in our life all the time. Breakups, financial difficulties, a loss of a job. Any one of those examples could lead to a mental health crisis. Another pretty significant cause of crises could be a chronic and unmitigated stress. We as human beings and most other animals are sort of evolutionarily designed to deal with stress, but not chronic stress. And so a simplest definition of chronic stress is when we are living in an environment which has stress in it, but the stress sore, which is what causes us a stress reaction, does not seem to go away. So think back to lions and tiger days, hunter-gatherer days. Yes, there were lions and tigers. Yes, there's periods in time when folks could not find the food they needed to survive. But those times were not frequent and didn't happen every day. And so evolutionarily, our minds and bodies were designed to deal with short periods of stress, overcome the stressor, and then get back to our normal functioning. Well, if you go to work every day and you work with a coworker or a boss that you can't stand, that over time leads to this idea of chronic stress. And if unmitigated, meaning if you don't quit your job or somehow resolve your discord with your boss or peer, the chronic stress will add up. In years past, so in the 80s, for example, we've even coined a term for these situations, right? If you remember to those days, we used to say something like he or she is going postal. We started using this term as a result of a postal worker losing their cool and bringing a weapon to their place of employment and shooting at their coworkers. Physical health problems, especially health problems that are chronic. So think of terminal illness like cancer or other severe diagnosis, usually coming out of nowhere. This is a major life event in somebody's life, which they are not prepared for. And with that surprise comes all sorts of emotional baggage that most people are unable to deal with in the present moment. Eventually, the good news is that most people do learn to deal with it with the right supports in place. If they need to get professional help from a therapist or a psychiatrist, get guidance from their physical health doctor to help them through the condition. But initially, it can take a person by surprise. And again, hopefully you're seeing a thread here now. An emotional response will ensue. We have great treatments for mental health disorders today. And so if an individual is diagnosed, even with the most severe disorders like schizophrenia or bipolar disorder, but they're receiving treatment, which typically includes medication and counseling and wraparound services, it works really well for most people most of the time. Treatments don't work if the individual does not participate in those treatments or stops participating. So if somebody stops suddenly taking their medications, this could lead to a mental health crisis or an emergency. And it could do this by two major ways. One is medications themselves, certain psychiatric medications, if stopped abruptly, can have severe consequences. And the second, if the individual actually needs the medication as a result of their mental disorder, and now they're not taking it, chances are their symptoms will return. And again, a potential mental health crisis can ensue. Lastly, a combination of not having the right social supports in place and not having existing coping skills to deal with some of these situations I just described. Both can lead to a mental health crisis situation. So think of being placed in a situation, any environment, but not having the skills or support of others to be able to deal with that situation. Often the immediate cognitive reaction is helplessness. And if the person is helpless enough, that could lead to a crisis. So what do we do? Well, the first step in any risky situation, whether it's mental health or otherwise, is to assess the risk. And most people can do this relatively well and relatively quickly. The key is to have the know-how of what questions to ask, and then the assertiveness to actually be able to ask these questions. We all have people in our lives, probably right now, all of you on this call, have someone you know, either directly or indirectly, that have struggled with their own mental health and have thought about hurting themselves. A World Health Organization has done a survey, and they keep doing the survey over and over again. And the unsurprising fact to those of us that have studied this for many years now is that most people have thought about dying. It's a natural continuum. The good news is that out of those people, only a tiny fraction, less than 5%, actually considered suicide. And then even a smaller fraction of those people have actually made attempts to hurt themselves. I keep using these words smaller and smaller. What I don't want to do is minimize the real fact. And the real fact is that every day in the United States, 130 people die by suicide. And that is 130 people too many. And so hopefully after today, you will be able to not only know this information, hopefully remember it, but also be able to apply it to your day-to-day lives. Because my ultimate goal is not just share this information with you, but for every one of you to be able to use this information in your lives. So let's start with the basic question. Do you feel like hurting yourself or anyone else? And its close cousin, are you having thoughts of killing yourself or someone else? In both cases, if the answer is yes, you need to continue asking more questions. And the three typical threads we try to address are plan, intent, and means. Plan refers to an exact plan of what the individual is going to do. Yes, I'm going to hurt myself. Yes, I'm going to kill myself. How are you going to do it? I'm going to take all of my prescription medications all at once, go to sleep, and never wake up. That's a plan. I'm going to use my shotgun that I have in my basement, and I'm going to put it in my mouth and pull the trigger. That's a plan. Intent refers to the strength of the desire to actually go through with the plan. Yes, I thought about taking all my pills, but I haven't filled my prescription yet. So that's one option. Or, yes, I just got back from my doctor's office. I picked up all my pills from Walgreens this morning, and I'm planning on taking all of them this evening. Much stronger intent. Means is the availability of whatever the intent and plan are described, the how it's going to be done. So for example, if the person is planning to overdose on their pills and yet they don't actually have the pills, well, that means there's no means. Or if the person is planning on shooting themselves with a weapon, but they don't have a weapon, means do not exist in that situation. In all of three components of plan, intent, and means, timing is a huge piece of the equation because each one of these components can change very quickly. So 1 minute, the person cannot have a plan, and then an hour later, they could have a plan. The intent can change even quicker. 1 minute, the person can be very hesitant about following through, and the next, the person all of a sudden is ready to do it right now. The part that's a little bit more difficult to sort of quickly be able to move to is the means. Because typically the means, if they're part of the plan, so taking pills, shooting themselves, is much harder to do quickly. You would still have to somehow see a doctor, get the prescription filled, or try to obtain a weapon, either from someone you know, purchase one. For this reason, we have wait periods when it comes to purchasing weapons. So a little bit more difficult. And so what we do see, though, as rare as this is, the individual might change a plan. So if the plan was to overdose on pills and they don't have access to the pills, so no means, they may change their plan. And they may decide, well, I'll just walk into moving traffic. And that's how I'm going to take my own life. Keep an eye on this. Again, timing is a huge piece. And so if you're having this conversation with an individual and they are either threatening to hurt themselves or someone else in the present moment with you there with them, either on the phone or in person, my advice would be at that point to not let them out of your eyesight. Because once somebody has threatened harm to themselves or someone else, that should sort of tick a trigger in your mind that says, okay, what do I do? How do I help this person? And in the next few slides, we'll get to the solutions. When it comes to drinking alcohol or using drugs, both of these substances can lead to either a crisis all on its own or an exaggeration of an existing mental health emergency or behavioral health crisis on top of. So, for example, we know that when people are under the influence of drugs and alcohol, their decision-making is not as good as when they're sober. And so when an individual is planning on hurting themselves or someone else, and drugs or alcohol are involved, the chances significantly increase of them being able to go through with those actions. So we really have to be careful. In a similar fashion, but without drugs or alcohol, our nourishment of food and water or liquids is equally as important. You have probably heard of the term hangry. And this is just a nice way of saying that when we get hungry, we get angry. Our bodies are telling our minds that you need something to eat. And if you don't have something in your body to nourish your brain and body, which brain, by the way, takes some more, the highest amount of energy in your entire organism, including your brain and body, goes to your brain. The amount of glucose that needs to be processed to give you the energy for your brain to function is much greater, for example, than your heart, your liver, your kidneys, or any other organs. And so, again, without food and water, you literally can't think straight. And then finally, medications. I've mentioned this on a previous slide. If someone is supposed to be taking medications and all of a sudden they stop, not only is it the symptoms would come back without the medications, withdrawal can also occur. And withdrawal is your body's and brain's natural reaction to when it has gotten used to a particular substance and then all of a sudden it's not there anymore. And so withdrawal symptoms can also be critical at this stage. When we are assessing suicide risk, which is probably the highest risk that we're talking about when it comes to mental health crisis, the direct question of, are you thinking about killing yourself, is most important. It's also the one question that most people are very hesitant to ask. Usually it's because they think that somehow they're going to give them the idea for doing it. This couldn't be further from the truth. We have done lots of research over the last 40 to 50 years on this very question. And there's no evidence to say that if you ask someone if they want to kill themselves, that you're actually going to be putting ideas in their head. So please, if you think that someone has a potential of wanting to harm themselves, ask the question. A few things you don't want to do is minimizing their experience, no matter what the experience is. We don't actually ever know what someone is going through, even if they tell us, because no two human beings are exactly alike. And so this idea that somehow you can put yourself in their shoes is somewhat erroneous. We all wear different size shoes, and even trying to put yourself in their shoes can sometimes go very astray. Instead, what I recommend folks do is practice what's called tactical empathy. It's a little bit different than this traditional idea of trying to feel how someone else feels. Our own feelings within our own brains can sometimes be very muddy, and we may change how we feel on a moment-by-moment basis. So it's virtually impossible to really feel what someone else's feels. Instead, try to be more compassionate. Try to understand how they feel and just leave it at that. You don't have to be in their shoes. Just be compassionate to what they're experiencing. Even if what they're describing as an experience is not something that maybe would put you in a crisis situation. Again, every person is not you. And so don't minimize their experiences. Don't act surprised. When you ask the question, are you thinking about killing yourself? And they say, actually, yes, I am. You ask the question. So you don't want to seem surprised when they give you the answer to your question. Again, in that situation, try to stay calm. Talk to them about their reasons, their situation. And as this conversation takes place, start to plan for what you're going to do next. Also, don't compare your own experiences. We all have had difficult situations in our lives, but in the moment of crisis, telling somebody that, oh, I know how this feels because this X happened to me is not going to help. And then finally, don't give advice or debate. This is not the time to debate the ethics of suicide, or is this the right time, or is this the right solution? Don't do any of this, because typically when we do try to intervene in crisis situations, the logical brain or this reasoning with the individual is not what's going to work in the end. What's going to work in the end is using tried and true methods that we know for a fact help. And what helps is dialing 988 and connecting the individual in crisis with trained professionals. And so really what your job is, or for most of us that either have not been thoroughly trained and educated in crisis response, or maybe live with someone or multiple people or work with people who could often escalate into a mental health crisis situation, is to buy us some time and get the individual to the right level of help that would actually work for them. There are trained crisis workers that man the 988 line 24/7. And so getting an individual to those folks is critically important. And it could be a resource, not just for the individual, but also for the caretakers of that individual. Often in crisis situations, there's this ripple effect. So it's not just the individual who's in crisis, it's everyone around them as well. Okay, so what can you do if you find yourself in these situations? This is where we talk about de-escalation. A typical definition of de-escalation is that of reducing the intensity of a conflict or potential violent situation. I often say that the best de-escalation, the best offense is defense, is to do everything we can for these crisis situations not to occur in the first place. This is a whole separate lecture that we could talk for several hours about. So what we're going to talk about in the next few minutes is actually, let's say you've tried everything you can and a crisis occurs anyway. Now what? You find yourself in the middle of a mental health crisis. Now you can't run away. You can't even call 988. You got to do something in that situation. So first and foremost, there are these 4 situations where chances are you're probably not going to be able to do anything. These are what we call the non-de-escalation situations, or where de-escalation is not effective, unless you have been very thoroughly trained in how to do this. And those are situations where you have person going through psychosis, severe intoxication, physical aggression, or high reactivity. In every one of these situations, there's a pretty good chance that if you try to de-escalate, you will only make matters worse. And this is nothing against a personal, any one of you listening to this today. It's just science. We have tons of research about these kinds of situations where people have tried to de-escalate the individual, and unfortunately, it only led to worse circumstances. On the other hand, everything else is definitely prone for de-escalation. De-escalation methods could be used during all sorts of mental health crises. Typically, we do this to maintain a level of calm in a stressful situation while reducing the probability that violence or harm will occur. So remember this, that if you remember nothing else from today, this one sentence, we help de-escalate situations to reduce the probability of violence and harm. It doesn't mean that violence or harm will not happen, but we are reducing the chances or reducing the probability. Let's talk about some of the techniques. They fall into these four broad categories. The first one is rapport, probably the most important one. This is where you get to create a relationship with the individual if you haven't had one created before. So think of strangers, or you take an existing relationship. So it could be a parent to a child, a coworker, you name it, and you change it ever so slightly. So obviously, if you know someone, you're not going to reintroduce yourself. But if it is a stranger, you would. You would use their name. So instead of saying he, she, use their name. Oleg, Helen, call them by their name and try to repeat that name as often as you can. Use future tense when you're having the conversation with them. Instead of saying, you did this, say, we will be safe. I will take you to a calmer place. Let's go somewhere where there's less people. Give them some hope. Create this with your own language, a feeling or an atmosphere of safety. You want this relationship, even if it's an existing one, to feel like in that moment, when someone is in a moment of crisis, they can trust you. And they can trust you more than they can trust anyone else around. The way we do this is by being genuine and authentic. And you can use phrases like, this is scaring me, or this is, you're acting out of character. Because what this allows the person to understand is even though you're scared, you're still speaking to them. You're next to them. You're trying to help. When we try to help someone who's in distress, the person in distress feels our desire to help. The moment that happens, you get to what I call getting to a yes, where they say, okay, I'll walk with you over there, or let's go chat more. Offer options. The more options you give the individual, the greater the chance they will take one of those options. Would you like to go sit on a bench? Would you like to go for a walk? Why don't we leave this apartment and talk over there? As many options as you can give, the greater the chance that that probability of an actual violence or harmful event occurring will be decreased. The second category of de-escalation techniques are all rooted in active listening skills. Typically, when someone is in distress, our own central nervous systems go into defense. We immediately make it about ourselves, and our own emotional distress rises. And that's, again, an evolutionary feature that you can't really sort of flip the switch on or override. Instead, you can calmly convince yourself in the moment that this is not about me. They don't want to harm me. They probably don't even want to harm themselves. But my job is to kind of get in between them and themselves. And so pay attention. Listen closely. Most of the time when we are in stressful situations, our ability to pay attention and listen closely goes away because our brains are simply trying to find a way to survive. When you're trying to help someone in a mental health crisis situation, you have to be able to tone down that reptilian brain that says fight or flight, and instead listen and pay attention to the individual you're trying to help. Don't interrupt. Let them speak. Often they will ramble, they will talk for a long period of time. Let them talk. Every minute that they're talking, they're not hurting themselves or someone else. And then as you're listening, practice empathy and validation skills. Validate their feelings. The phrase I like to use is you feel because. You feel frustrated because you didn't get your cigarettes this morning. You feel upset because your show got canceled. You feel really pissed off because he yelled at you. Every time you use that you feel because phrase, it communicates to the person, they're listening, they care for me, and maybe they're even right. All of that allows you to connect closer to the person and ultimately de-escalate the situation. If they say something you don't understand, clarify. Summarize and paraphrase. Basically, restate what they just said in your own words. Often, when someone hears their own words said back to them by someone else, it sounds slightly different, but it rings true. And finally, use your nonverbal prompts. Those of you that have ever been trained in active listening, the nodding of the head, lots of therapists, social workers do this. We almost kind of bred to do this back from graduate school. But then also practice the nonverbal communication skills. These have a lot more to do with your immediate surroundings, as well as paying attention to your own body and mind. So things like environmental awareness. Look around. As you're engaging in a crisis de-escalation situation, pay attention to what's around you. Are there large, heavy objects that could be used for harm? Move away from them or remove the objects. Is there something that's either could be used as a trap? So, for example, if you're positioned between the person and the door, where you could potentially find yourself in a harmful situation, move away. Make sure that you always have a way to get out of the physical environment. Maintain good eye contact. A lot of times when we're in stressful situations, even if we're trying to resolve those situations and de-escalate, we lose eye contact because, again, we're preoccupied with how dangerous the situation can potentially become. Maintain eye contact. Probably the hardest thing on this list is remain calm, right? We hear this all the time. What we must do, though, almost at the same time, is while we are trying to convince ourselves to remain calm, what you don't want to do is to tell the person in distress to calm down. This is one of the most interesting paradigms when it comes to de-escalation. All you really want to do is tell the person, calm down, relax. But what really you should be doing is saying those things to yourself inside your own mind. Because when you tell someone to calm down and relax while they're in distress, that typically makes things worse.
I just wanted to pop in and let everyone know we've got about 5 minutes left. So we're going to start wrapping up. I don't see any questions in the Q&A, but if anyone has questions, now would be a good time to drop them in there.
Perfect. Thank you. Okay. I'll skip to the last couple of slides here. So after, let's assume you did a great job and you were able to resolve and de-escalate the crisis. Two things you want to do immediately is debrief. You want to plan for the future, meaning what's going to happen next. Yes, right now, they're not going to harm themselves or someone else, but what are they going to do when they leave? Do they have someone that can help them with supports? Do some kind of a risk assessment after you leave. Understand what happened. What were the triggers? Was it something someone said? Was it a particular time of the day? Were there other circumstances related things that triggered this crisis in the first place? Whatever it is, recognize what they are, but also recognize what helped with the crisis. Was it you? Was it something you said? Was it something you did? Was it them? Was it simply the passing of time? When enough time passed, they calmed down and the crisis was resolved. No matter what the outcome is, you still want to connect them with a treatment provider. You want to ask if they already have a behavioral health provider. If they do, help them connect with that person, make an appointment. Ask if they need help driving them to that appointment. Do whatever you can to re-engage them with treatment. If they don't already have a treatment provider, help them find one. Ask if they have health insurance. If they do, help them call the insurance company. You can always call NAMI for support, or you can always search for a provider on SAMHSA's.gov website. At the end of the day, the choice is theirs. You can't force someone to get treatment, but you can assist and provide encouragement and support. In the 2 minutes we have left, here's what hopefully you learned today. Crisis, especially mental health crisis, can present in all sorts of ways. They can be presented in different environments, at home, at school, at work. There's no one way where mental health crisis happens. Assessing for risk is the biggest key in determining whether there's an imminent danger or not, whether it's threat to themselves or someone else. In an emergency where you know that this is way above your head and you can't really help other than maybe buy some time, call 988. 988 has trained professionals that will help in almost any situation 24/7. Ultimately, if you find yourself in a crisis situation, your safety and the safety of others is the #1 priority. And so if you think that you can't safely de-escalate a situation, get out of there. Because the last thing we want is multiple people getting hurt unnecessarily. Knowing and learning the skills, especially de-escalation skills, can help you manage a crisis more effectively. It will not necessarily help you prevent one. And then lastly, once the crisis is resolved, make sure that you at least suggest to the individual for them to connect with a treatment provider and provide them opportunity or support to be able to do that, including offering to drive them there, including offering to make a phone call, somehow support their need to connect with a treatment provider. Thank you. Are there any questions in the chat?
I don't see any questions right now. We do have 39 people on here. So I guess I'm just going to ask, can everyone hear us? And is there any trouble accessing the Q&A or the chat, which is on the right side of your screen? So if you do have any questions, now's a great time. But
I think Heather has a question and Matt has a question in the chat.
Why aren't they coming up on my...
It looks like they're coming in on the session.
Heather asked, what would be the differences in dealing with youth?
Yeah, it's a great question, Heather. Lots of differences. So one of the most fundamental differences is it depends on how young the person is. When it comes to children and adolescents, probably one of the most under sort of considered but most prevalent factors is developmental factors. So how you would deal with a 5-year-old in a mental health crisis or emergencies is very different than how you would deal with a 15-year-old. Think about things like impulsivity, volatility, lack of logical thought patterns, lack of many existing healthy relationships. All of these things are part of the decision-making in the process of, well, what do you do next? And so my recommendation would be when it comes to kids and adolescents in a mental health crisis or emergency is to immediately reach out for help to someone who's trained and specializes in that population.
And I believe Matt also has a question. He said, how do you suggest helping if someone refuses to acknowledge that they are not currently in touch with reality?
Yeah, it's a great question. So typically that question is a reference to psychosis of some kind that is visible. So psychosis takes shape in different forms. One of those is the combination of those hallucinations I mentioned earlier, auditory or visual. but also paranoia. This is one of those things that we didn't talk about today, but often plays a role when it comes to addressing mental health crisis, especially with people that are psychotic. And so what in the most basic sense, when someone is paranoid, not only do they think that something is happening that's not really happening, they are suspicious of those that are trying to help. And that is really the crux of this question. And so my advice would be to get someone in there that knows them well already, someone with an established relationship. A perfect stranger is not going to be able to help someone who is in a psychotic state and who's paranoid and doesn't want anyone helping them. You want to find someone that they have a relationship with.
That's a terrific question. And Matt, I definitely tomorrow at there's another workshop tomorrow at 2:20 p.m. It's going to be with Dr. Mark Comrade, and the whole topic is how to convince someone to get help. He's a regular speaker at NAMI stuff, and he'll be covering that question in detail tomorrow afternoon. If you want to join us for that one, I'll be there moderating as well. Oleg, thank you so much. This was a terrific presentation. So thorough and so detailed. We really appreciate having you. Thanks so much, everybody. We're out of time. We got to get you all to lunch, and hopefully we'll see you guys again in the afternoon.
Thank you. Take care, everybody.